Thank you very much, and it's a privilege to introduce our local guy here, Dr. Rajat Gupta. He is a DNB pediatric and did a fellowship in pediatric cardiology, and he's heading the unit of Fortis. Because there's no pediatric cardiologist, obviously, in this entire region in the private sector. So he is the only person where all people from North India, Afghanistan, Iraq, and other countries flock to get the procedures done. So he obviously is very keen to do interventions in congenital heart and in the neonates. Dr. Rajat, now the floor is for you.
Good morning, everyone. I will be discussing ventricular septal defect, the size and place matters. In this talk, I will be discussing normal ventricular septal anatomy, how to image the ventricular septum by echocardiography, different types of the VSD by their location, and assessment of the hemodynamics of ventricular septal defect. A ventricular septum is a complex anatomically. It is divided into four parts: the inlet septum, trabecular septum, the outlet septum, and the membranous septum. If we look at this specimen carefully, the right ventricular anterior wall has been removed and the right ventricular aspect of the interventricular septum is being shown. The septum, as we discussed, this consists of four parts. We will be discussing the inlet ventricular septum first. We can see the septal leaflet of the tricuspid valve marked by the black sketch and the distal caudal attachment of the septal leaflet marked by the yellow dots. The area between this black line and yellow dot is the inlet septum. This is also represented on the adjacent cartoon by the blue color. We can also see this Y-shaped prominent muscle band called the trabecula septomarginalis. I can show you here. So this is the trabecula septomarginalis. This is the Y-shaped band with vertical limb and the horizontal limb. The horizontal limb, one of the horizontal limb is extending posteriorly and inferiorly towards the inlet septum. The other vertical limb is extended superiorly and anteriorly towards the outlet septum. The area of the interventricular septum between these two limbs is the outlet septum. It is marked by this green color in this cartoon. The remaining white area, large white area inferior to the inlet septum and below this outlet septum is the trabecular septum. A small part of the ventricular septum is very thin. It is called membranous septum and it is lying at the junction of these three septum. This is the membranous septum. So interventricular septum, as we said, is a complex anatomically. It is a curved surface and should be seen from the multiple echocardiographic views for the good definition. We always start with the subxiphoid view. A subxiphoid view gives us the good anatomical view of the interventricular septum, its different parts. Subxiphoid short axis view is first of all imaged, and we can see in the cine on the left side, the interventricular septum is shown. The aortic valve is well seen. The area of the interventricular septum immediately below the aortic valve and in close relation to the septal and anterior commissure of the tricuspid valve is the perimembranous septum. I can point, this is the perimembranous septum. It is lying immediately below the aortic valve cusp in the region of non-coronary sinus. And this is the anterior tricuspid leaflet. Along the interventricular septum is the septal tricuspid leaflet. The commissure in between the two leaflets, the anteroseptal commissure, is closely related to the perimembranous region. With slight rightward shift, we can see the pulmonary artery is very well seen. The area of the septum immediately below the pulmonary valve is the outlet septum. With further rightward sweep, we can see the rest of the trabecular septum. The area of the septum close to the probe, this part is the posterior interventricular septum, while away from the probe, this part is the anterior interventricular septum. With further rightward sweep toward leftward sweep from the towards the apex, we will show us the apical interventricular septum. In apical four-chamber view, the area of the septum which is seen is the posterior part of the septum. Towards the base, that is between these two leaflets, the tricuspid valve and the mitral valve is the inlet part of the septum or the posterior part of the septum. While with the anterior sweep, when the aortic valve is just seen, the area here is the membranous septum, small area between the aortic valve and the tricuspid valve is the membranous septum. We also can see the anterior muscular VSDs with the anterior sweep in the apical four-chamber view. In parasternal long axis view, the area of the septum immediately below the aortic valve is the outlet septum. We don't see the perimembranous area in this region. In the parasternal short axis view, the area of the septum between this tricuspid valve, immediately adjacent to the tricuspid valve, is the membranous septum. A defect in this location at 9 to 10 o'clock position is a perimembranous defect. Beyond that, after 10 o'clock to 1 o'clock position, till this pulmonary valve, this is the outlet septum. The defect in this outlet septum is the outlet VSD. If the VSD is very closely related to pulmonary valve, the superior margin is formed by the pulmonary valve, then it is a doubly committed or juxta arterial VSD. From the same parasternal short axis view with posterior sweep, we can see the muscular or trabecular interventricular septum. The area close to the probe, this is the anterior interventricular septum, and away from the probe, this is the posterior interventricular septum, and middle part is the middle part of the interventricular septum. We follow the Anderson classification of the ventricular septal defect most commonly, and there are 4 types of VSD according to the Sir Anderson. So first type of VSD is perimembranous VSD. Second are the muscular or the trabecular VSD, then doubly committed VSD, and then the inlet VSD. We'll be seeing each type of VSD in detail. A perimembranous VSD is anatomically related to the anteroseptal tricuspid valve commissure, as we have seen, and aortic annulus in the region of non-coronary cusp. A VSD is located immediately below the ventriculo-infundibular fold. So these are called the infracrystal VSD. This is a less common name for the perimembranous VSD. So we always start with the subxiphoid short axis view. We can very well see a ventricular septal defect immediately below the aortic valve, and it is closely related to the anteroseptal commissure of the tricuspid valve. Please look carefully. This anterior leaflet of the septal, anterior tricuspid leaflet is very well shown, and along the septum is a septal leaflet. So this is a anteroseptal commissure, and this aortic valve is a, here is a non-coronary sinus. So perimembranous VSD is very closely related to the aortic valve in the region of non-coronary sinus and anteroseptal commissure of the tricuspid valve. The VSD shown in this cine is a large VSD because the size of the VSD in this cine is very close to the size of aortic valve annulus. So when a VSD is more than 2/3 the size of the aortic valve annulus, it is a large VSD. If we see the apical four-chamber view, in true apical four-chamber view, when both the AV valves are opening, we don't see the perimembranous region. The ventricular septum at that part is intact. With slight anterior sweep, when the aortic valve is opening, we can very well see a large perimembranous VSD immediately below the aortic valve and in close relationship to the septal leaflet of tricuspid valve. This is a perimembranous defect. As I said, in parasternal long axis view, we don't see the true perimembranous defect, but with slight posterior sweep, we can still see the perimembranous VSDs. In parasternal short axis view, a perimembranous VSD is seen immediately adjacent to the septal leaflet of tricuspid valve at 9 to 10 o'clock position. With color flow interrogation, we can see a laminar red flow through this VSD. A red flow means the shunt is happening from left ventricle to the right ventricle, and laminar flow means there is no significant pressure difference between the left ventricle and right ventricle. The right ventricle pressures are at the systemic level, and there is pulmonary artery hypertension. Pulmonary artery pressures are near the systemic pressure. A perimembranous VSD can be restricted by 3 different mechanisms: ingrowth of the membranous septal tissue from the VSD margins and septal leaflet of tricuspid valve, and rarely by the aortic valve cusp prolapse. We can see here a small VSD in the perimembranous region. We can also recognize some tissue ingrowth from the VSD margins, which is trying to close the VSD or restricting the VSD further. The color flow jet through this small VSD is turbulent and red. Red means it is happening from left ventricle to the right ventricle, and turbulent means there is a significant pressure gradient from the left ventricle to the right ventricle. So pulmonary artery pressure in this type of VSD are likely to be less or near normal. A VSD, as we have seen, can be restricted by the tissue ingrowth from the septal leaflet of tricuspid valve, forming an aneurysm, also known as membranous septal aneurysm. So what happens when there is a tissue ingrowth which is restricting the VSD? Sometimes this tissue separates the VSD from the aortic margin, produces a margin between the VSD and aortic valve cusp, and this kind of VSD then can be closed with the transcatheter device closure. In this picture also we can see the VSD is being restricted by the tissue ingrowth, and the VSD margin is separated from the aortic valve. The color flow is turbulent. The left atrium and left ventricle are dilated. Means still this is a quite significant shunt is happening through the VSD. Same VSD in parasternal long axis view with inferior tilt, because perimembranous VSD cannot be seen in the true parasternal long axis view. We can see the aortic valve is not seen. We have swept the probe posteriorly. The perimembranous VSD is seen being restricted by the membranous septal aneurysm. As said, I have said this kind of VSDs which are being separated from the aortic valve can be closed with the transcatheter approach by the device. So we have closed this VSD through the device, and see the device is so closely related to the aortic valve, but this is not causing any aortic regurgitation or tricuspid regurgitation. Sometimes these VSDs can be completely closed by the membranous septal aneurysm. As in this scenario, you can see there is a large defect in the perimembranous region, which is being closed by the membranous septal aneurysm being attached to the margins of VSD. There is no flow from the left ventricle to the right ventricle. The left atrium and left ventricle are dilated because of presence of PDA in the same patient. Aortic valve prolapse can also happen in the perimembranous region. Most often it is the non-coronary cusp, but less commonly the right coronary cusp, or rarely both the cusp can prolapse through the perimembranous VSD. This happens because of the venturi effect of the high pressure VSD jet, and the aortic valve cusps are being sucked in. So this is an apical 4-chamber view showing defect in the perimembranous region, because with the anterior sweep the aortic valve is seen. The defect is immediately below the aortic valve. You can see the aortic valve is prolapsing through the VSD. The VSD jet is turbulent, it is being restricted, and there is some degree of aortic valve regurgitation. In parasternal view, the long axis view also, you can see the aortic valve cusp is prolapsing through the VSD, which is restricting the anatomical size of VSD. The VSD jet is again turbulent, and there is some degree of aortic regurgitation. The aortic valve cusp prolapse is clearly being recognized. This is a parasternal short axis view. You can see the non-coronary cusp. You can identify the cusp which is being prolapsing through the VSD is a non-coronary cusp. In this region, there is aortic regurgitation and a restricted VSD. The degree of aortic regurgitation because of cusp prolapse can be mild, moderate, or severe. In this view, you can see there is a dilatation of the left atrium and left ventricle. The VSD is being restricted by the cusp prolapse, and there is a severe aortic regurgitation. The VSD is small. This VSD cannot cause for left atrial and left ventricular dilatation. This is because of aortic regurgitation. This is a severe aortic regurgitation caused by the aortic cusp prolapse through the VSD. In this view, you can see the severe distortion of the non-coronary cusp, severe aortic regurgitation. Now coming to the outlet VSD, the outlet VSDs are divided into subpulmonary VSD and intraconal VSDs. The intraconal VSDs are located in the conal septum, but they are separated from the pulmonary valve and also from the tricuspid valve. So they are bounded on all sides by the muscular rim of tissue. While if a VSD is extending up to the pulmonary valve, so that the superior margin is being formed by the pulmonary valve, or the area of fibrous continuity between the pulmonary valve and the aortic valve. This is juxta-arterial doubly committed VSD. So outlet VSD can be both. If it is reaching up to the pulmonary valve, it is juxta-arterial or doubly committed VSD. Or if it is being separated from the pulmonary valve on this side also from the tricuspid valve, it is a intraconal or outlet muscular VSD. So this is an example of large intraconal or outlet muscular VSD. We can see from the subcostal short axis view that VSD is being separated from the pulmonary valve by the small muscular tissue. This is not a perimembranous VSD. You cannot see a tricuspid valve here. This is seen on the rightward sweep from the short axis. This is away from the perimembranous region or the away from the tricuspid valve. So this view is shown in the same view is shown in the inverted position. In apical four-chamber view, these outlet VSDs are seen with much anterior sweep. The aorta is fully seen and the VSD is lying very much anteriorly. In parasternal long axis view, this VSD is seen immediately below the aortic valve. Perimembranous VSDs are not seen in this view. This is a parasternal short axis view. You can clearly see defect in the outlet septum, which is being separated from the perimembranous region and from the pulmonary valve by the muscular tissue. So this is a pure outlet muscular VSD. This is common to have a right coronary cusp prolapse through the outlet VSD. So this is a parasternal long axis view showing the right coronary cusp prolapsing through the VSD. There is no aortic regurgitation in this case. This is again an example of outlet muscular VSD being restricted by the right coronary cusp. So you can see the defect in the outlet septum is large. This is being restricted by the cusp prolapse here. In this case, there is a trivial aortic regurgitation with RCC prolapse. Now coming to doubly committed VSD, as we have already said, the doubly committed VSD, the superior margin reaches to the pulmonary valve. It is bounded by the fibrous continuity of the aortopulmonary junction. You can clearly see this is the pulmonary valve here, and VSD is immediately below the pulmonary valve. On a apical four-chamber view, doubly committed VSD is seen with anterior sweep, and in parasternal long axis view, the doubly committed VSD is seen immediately below the aortic valve. A parasternal short axis view shows there is no muscular rim separating the VSD from the pulmonary valve. The roof of the VSD is being formed by the aortopulmonary fibrous continuity. It is also common to have right coronary cusp prolapsing through the doubly committed VSD, which will restrict the ventricular septal defect and will produce a varying degree of aortic regurgitation. Here you can see there is a moderate aortic regurgitation with small VSD jet is also being recognized in parasternal long axis view. Parasternal short axis view showing the VSD jet immediately below the pulmonary valve and moderate aortic regurgitation. Now, we'll discuss the inlet ventricular septal defect. As we have already discussed, the inlet ventricular septal defect are the defect in the septum, which is bounded on either side by the atrioventricular valve. In the subcostal xiphoid subcostal short axis view, the inlet septum is seen between the septal leaflet of the tricuspid valve and mitral valve. The superior boundary of the inlet septum is the anteroseptal commissure, and the area in this part of the septum is the inlet VSD. In apical four-chamber view, this VSD is seen in true apical four-chamber view without any anterior sweep. We can recognize when both the AV valves are opening, we are looking at the inlet septum. There is a large VSD present here. We can also recognize a small muscular VSD here, which is an inlet or posterior muscular VSD. if the VSD is bounded superiorly by the small rim of the muscular tissue, which is separating the VSD from the AV valve fibrous continuity. This VSD is inlet muscular VSD. Or if there is a no muscular tissue separating the VSD from the AV valve, this is a true inlet VSD. This is again a inlet VSD. Inlet VSD are important component of the AV canal defects. We are not going to discuss AV canal defect further because these are being discussed in another talk. This is a AV canal defect with common AV valve and inlet VSD. Inlet VSDs are sometimes associated with overriding and straddling AV valves. In straddling AV valves, what happens? The caudal apparatus of one of the AV valve is attached on the opposite side, means the tricuspid valve has got caudal attachment on the left ventricular side, while the mitral valve have caudal attachment on the right ventricular aspect of the interventricular septum. So grade 1 straddling is when it is grade 1 and grade 2 straddling, the caudal apparatus is attaching on the opposite side of the interventricular septum, while in grade 3 straddling, the chordae of the valve is attaching to the free wall of the opposite ventricle. In this example, there is overriding as well as straddling. The mitral annulus has overriding and it is reaching and it is draining into the right ventricle. The caudal attachment of the mitral leaflet can be seen to the right ventricular free wall. So this is overriding as well as grade 3 straddling of the mitral valve through the inlet VSD. This kind of arrangement prevents the two ventricle repair and patient has to be palliated to a single ventricle pathway. Coming to the muscular VSDs, the muscular VSDs can vary in position. They can be anterior muscular, mid muscular, posterior muscular, marginal. They can be multiple. They can vary in size. So as we have seen that there is a large trabecular component of the interventricular septum. The VSD is located, anterior part is called anterior muscular, in the middle part are mid muscular and posterior part are the posterior muscular VSD. This is towards the apex are apical VSDs. Towards the anterior interventricular grooves are marginal VSDs, anterior marginal VSDs. From a subcostal xiphoid view, we can see the ventricular septal defect in the anterior portion of the interventricular septum. We can see the pulmonary valve is being opened here. So pulmonary valve is a very anterior in position. Whenever we can see a VSD and pulmonary valve, we can assume that this is an anterior VSD, while the VSD which are being seen while the both AV valves are being opening are posterior VSDs. So this is anterior muscular VSD in this view. In a apical four-chamber view, the anterior muscular VSDs are seen with anterior sweep when the aorta has been closed and pulmonary valve is being opened. In parasternal long axis view, again, very much anterior sweep is required to image this anterior muscular VSDs. Parasternal short axis view, this VSD is located close to the anterior interventricular groove. This is an example of mid-muscular VSD, apical four-chamber view. Parasternal short axis view showing VSD is being in the middle portion of the interventricular septum. This is showing multiple VSDs, a moderate size anterior muscular VSD and multiple small anterior muscular VSDs. Again, the multiple anterior muscular VSDs are being shown. From the parasternal long axis view also, you can recognize small multiple VSDs in the anterior interventricular septum. Sometimes the VSD can be so large, it amounts to a single ventricle. You cannot repair this kind of VSD. You cannot create such a large interventricular septum. So these patients again will have to go on a single ventricle palliative pathway. This is an interesting VSD, Gerbode-type of defect. When the pars atrioventricularis, we know the membranous septum has two components, pars interventricularis and pars atrioventricularis. Pars atrioventricularis separates the right atrium from the left ventricle, and when there is a defect in this part of the septum, it is a true Gerbode type of VSD. This is an obligatory shunt because whatever the PA pressures may be, whatever the pulmonary vascular resistance may be, shunt will always happen left to right. So this is an obligatory shunt. So this is the pars atrioventricularis, the membranous septum, which separates the right atrium from the left ventricle. And if this is deficient, the shunt will happen from left ventricle to the right atrium through this defect. This is a true Gerbode defect, which is shown in this image. The shunt is happening from left ventricle to the right atrium through the true Gerbode defect. But when the defect shunt is happening from left ventricle to the right ventricle and then through the anterior septal tricuspidal commissure into the right atrium, this is indirect Gerbode defect, and this is the more common type of the lesion. In this defect, what happens? The tricuspid valve resects the perimembranous VSD, and jet traverses from left ventricle to the right ventricle and from right ventricle to the right atrium through the anterior septal tricuspid commissure. See what is happening. There is a part of the VSD which is shunting from left ventricle to the right ventricle, and some part is going to the right atrium through the tricuspidal commissure. Now you can recognize it more clearly. This blue component is first going from left ventricle to the right ventricle and then through the tricuspid valve commissure into the right atrium. This is indirect type of Gerbode defect. Now coming to assessment of hemodynamics of ventricular septal defect, I will be discussing left atrial and left ventricular enlargement, size of the VSD, shunting pattern through the VSD, how to assess the pulmonary artery pressures through the VSD, and effect of additional lesion. Left atrial and left ventricular enlargement. On the first scene, you can see the left atrium and left ventricle are clearly enlarged. This means there is a significant left to right shunt is happening, and QP, the pulmonary blood flow, is increased. The second scene is also from a patient with large VSD. There is no enlargement of left atrium and left ventricle. In fact, you can recognize the right ventricular hypertrophy. So this is a scene from a VSD Eisenmenger patient in which the shunt has reversed. There is no more increased pulmonary blood flow, and the LA and LE enlargement has regressed. In case of borderline enlargement, when you are not sure whether the left atrium and left ventricle are enlarged or not, you can use the Z-score method, in which you can use what is the standard deviation of the left ventricular size. So we have got this app called CardioZ, which can be used. You can give the inputs of weight, height, age of the child, and actual size of the left ventricular diastolic dimension. And this will give you the standard deviation score or the Z-score. If it is more than 2, it means the left ventricle is dilated. The size of the VSD.
I'm extremely sorry to intervene because talk was supposed to be 20 minutes and it's 30 minutes plus. So I think we can take up question answers, Dr. Rajat.
Yes, sir, sure. So I can see questions here. Is the calculation of QPQS required while reporting VSD, especially in adult patients? So we don't actually calculate the QPQS, but we have to give the idea whether there is a QP is increased or not. And this is given by the exact left ventricular dimension and standard deviation score, as I have discussed. Whenever the LV is dilated, it means the shunting is more than 1.5 or 2:1. And if the LV is not increased, it means the QPQS is insignificantly increased. So we always give the left ventricular and diastolic dimension and its Z-score. We don't give actual QP and QS. Can you please repeat the difference between outlet and WVSD? I guess you are asking outlet and doubly committed VSD. So a doubly committed VSD, the superior border will reach up to the pulmonary valve. The pulmonary valve will form the superior margin of the ventricular septal defect. It is called juxta-arterial or doubly committed VSD. If there is a muscular rim separating the VSD from the pulmonary valve and also from the tricuspid valve, the VSD is in the superior to the septomarginalis, crista septomarginalis, then it is a intracolonal or outlet VSD. The only difference between two is one is reaching up to the pulmonary valve and other is not reaching. That is being separated from the pulmonary valve. I can see only 2 questions, sir.
I think great. And for sake of time, I think we move on. Back to the organizers, please. Next, I think, is my presentation, and I probably